we will discuss the common mechanisms involved in supraventricular tachycardia. Most common would be a re-entrance circuit involving either the AV node alone or AV node and part of the ventricle. When it is AV node alone, it is AV nodal re-entrant tachycardia or AVNRT. When the ventricle is also involved, it is usually an accessory pathway mediated tachycardia known as atrioventricular tachycardia. And another variety is an automatic abnormal focus within the atrium. These are the different types of basic mechanisms. A diagrammatic illustration of the types of mechanisms which I just mentioned. One is a re-entrance circuit, which is also sometimes called as circus phenomenon, re-entrance circuit or circus phenomenon. For this, there should be unidirectional conduction. There should be some unidirectional block somewhere, then only this circuit will be formed. Otherwise, if the circuit is conducting without any unidirectional block, the area will get depolarized and become refractory, so that abnormal circuit will not be formed. So if you take any re-entrance circuit, there will be an area of slow conduction. In atrial flutter, it is usually the isthmus, that is either mitral isthmus or tricuspid isthmus. Mitral isthmus is just above the mitral annulus below the left inferior pulmonary vein, while right atrial or the tricuspid isthmus is just above the tricuspid annulus, that is known as the cavo-tricuspid isthmus, near the region of the inferior vena cava and the tricuspid annulus. So that is the commonest mechanism for atrial flutter. But more commonly, we see this re-entrant tachycardia is either AV nodal re-entrant tachycardia or atrioventricular re-entrant tachycardia. This is just a depiction of an abnormal focus going on in automatic atrial tachycardia, and the signals are just propagating. This need not be in one direction. Just because I got a symbol like this, I put it here. It can be in all directions, so that the atria will be depolarized and the circuit continues, so that you can have an automatic atrial tachycardia. Depiction of the basic circuit in atrioventricular nodal re-entrant tachycardia, AVNRT. The circuit is within the AV node when there are two pathways, fast pathway and slow pathway. So this is when there is dual AV nodal physiology. Usual atrial impulse comes down fast into the ventricle through the fast pathway. It also goes through the slow pathway, but it does not manifest because conduction is more faster in the fast pathway. But a premature beat sometimes find that fast pathway is refractory, as it has a longer refractory period, while slow pathway has a shorter refractory period. Then it, instead of going down the fast pathway, it can go down the slow pathway, and then when it reaches here, fast pathway would have recovered and it will go back. That is the slow fast variety of AVNRT. The other way around also is possible sometimes, fast slow variety. Then there is also slow, but commonest would be a slow fast AVNRT. And because it occurs through the slow pathway initially, there is a PR jump, because there will be slow conduction through the slow pathway, then it will manifest as a PR jump. There will be an increase in PR interval of 50 milliseconds or more compared to the previous sinus cycle. When the supraventricular ectopic occurs and initiates the tachycardia, it conducts down the slow pathway in slow fast variety, so that the PR interval of the first beat will be longer than the previous sinus beat by at least 50 milliseconds. That is known as PR jump in AVNRT, usually made out during electrophysiology studies when you give an extra stimulus in the right atrium. But occasionally you can get it recorded within the regular ECG also, if you are lucky enough to capture the exact initiation of the tachycardia as occurs in recurrent supraventricular tachycardias while it is being monitored in the ICU. This is depiction of mechanism of abnormal circuit in WPW syndrome, atrioventricular reentrant tachycardia. There are two pathways, one the normal AV nodal pathway, another is the axillary pathway. For simplicity, I have put only one pathway, but there could be other pathways also, lateral pathways, postroceptal, septal. So many types of pathways are possible in WPW syndrome, left-sided and right-sided. Depending on these, the ECG pattern may differ. And common is about 90% is orthodromic variety. That is, downward conduction is through the normal AV pathway and retrograde conduction is through the axillary pathway. That is orthodromic conduction. In orthodromic conduction, the QRS will be narrow because initial activation of the ventricles is through the normal conduction system. Retrograde will activate the atria and the P wave will be depending on where it is activating the atria initially. If it is right-sided, it will start from here, left-sided here, and it could be posterior, anterior, wherever the pathway is, the P wave, if you are able to see, the morphology will change. But very often, you will not see P wave because it may be buried within the end of the QRS. You may see as pseudo S, pseudo R, like that. So, different types of pathways are possible, and I have described the orthodromic conduction. Next is antidromic conduction. Initial conduction down the axillary pathway, so that when it reaches the ventricle, rest of the ventricle, both sides are activated through the ventricular muscle. Initial activation is fast through the axillary pathway, but rest of the activation is through the ventricular myocardium, so that QRS will be wide. That is about 10% of AV NRTs in WPW syndrome. It is known as antidromic tachycardia. Antidromic tachycardia showing wide QRS. When it comes to the emergency department, it will resemble a ventricular tachycardia. You might cardiovert and then take an ECG. It will show the WPW pattern. The other way around also is, that is in orthodromic tachycardia, narrow QRS tachycardia. Also, you won't see evidence of WPW syndrome during the tachycardia. It will be just like a narrow QRS tachycardia. When you convert it either with adenosine or by DC shock if required, and then take an ECG, the sinus rhythm ECG will show the classical pattern of WPW syndrome with short PR interval, delta wave. That is how you differentiate these types of tachycardias